welcome everyone. I'm Nigel Evans. I'm the Chief Executive of the Nuffield Trust, and this is the second in the series of events where we're perhaps having a bit of a detailed look at some sort of commonly held ideas and thinking about healthcare policy and healthcare delivery, which perhaps need a bit of a second look because there appear to be quite a few well-known facts and ideas that when you look at them closely turn out to be either require much more nuance in how you examine them, or indeed in some cases to be quite seriously wrong. And the one we've chosen today is a favoured slogan, which is more money to the front line, which sounds, apart from the distressing number of military metaphors that the health NHS tends to use, I think may have some other deeper problems in terms of how it's conceptualized and how the actual work of people at the clinical front line is actually constructed, and how they spend their time and how they're made more effective, and indeed what is it that makes them more effective. So we're going to have a bit of a provocation from Steve Black, who you may have seen writing a series of very thought-provoking and interesting articles in the Health Service Journal, but has also been writing on LinkedIn and other places on this and related topics. And I thought we'd get him to give us his perspective, because it brings a number of challenges to the way that we normally think about that. And then we're going to have Dr. Ron Agblay from the Royal Free Group, and Dr. Rebecca Rosen, who's a senior fellow, a clinical fellow here, also a GP, give us a bit of a perspective, and then we'll have an opportunity for people on the floor to participate. Please use the chat to give comments and thoughts as we go along. Don't wait to the end. We'll be monitoring those, and then with a bit of luck, we'll have a good time to bring people in to add to the analysis. So I think with that, Steve, I say over to you. I think you're sharing your screen, and I'll pass the baton to you. Thanks.
Right, can you all see that?
Yes.
Yes.
So I'm going to make the argument that the relentless repetition and the consequences of the idea of more resources to the front line has actually hurt the NHS badly. And I'm going to illustrate that by talking about three things, one of which has nothing to do with the NHS, but it will illustrate the points in an environment where none of you will bring your prejudices about how the NHS works to the conclusion. And that first story is from California, so it's not even from the UK. About 20, 25 years ago, California was worried about the scores in their primary schools, the reading scores. And they decided, based on a randomized controlled trial done in Tennessee, that one of the things they needed to do was to reduce class sizes, because there'd been a study in Tennessee that said lower class sizes, we get better reading scores, and we get disproportionate raises in the reading scores for disadvantaged children. And California was worried about that. So California did the experiment. In a short period of time, they halved the class sizes, doubled the number of teachers for those classes, and then they checked the scores. And the experiment was a disaster. Everything got worse. But they did something which is not often done in the NHS. They went back and asked, why? What went wrong? And what they discovered was, well, several problems. I will only quote a handful, but they illustrate one of the things that goes wrong when you focus on the wrong things. One was quite a lot of the teachers they had to recruit to cover twice as many teachers were much less qualified than the teachers they had. So the quality of teaching went down. They didn't actually have a lot of space in the schools, so they had to take space from other places, and the spaces were not as well designed for the purposes of teaching, so their reading scores went down. And they had to displace a lot of other activities from those rooms because, well, they were doing things like remedial classes for some of the deprived kids. And at the end of the day, the whole experiment, loads more resources to the front line in that case, was a disaster because of the trade-offs they didn't consider when they made the policy. That's a key point we'll come back to. So let me try and explain what I'll do for the rest of the 10 minutes. We keep saying more resources to the front line in the NHS, but I want to tell two particular cases where we know that staff can't fix the problem, and a more general case, what has the result of prioritizing frontline staff done for the rest of the NHS? And then we'll reach the conclusion, actually, it isn't the right approach. So let me first try and show an example of where more resources to the front line has been a big claim as a positive idea for the NHS. And this comes from an interview Andrew Lansley did recently with the Institute for Government, where it's worth reading the whole interview for his lack of having learned anything from his time as health secretary. But he boasted about what he'd done to get more resources to the front line. Very explicitly, he basically said management was the enemy, and he'd sacked enough of them to put an extra $1 billion a year into the NHS front line. So he was rare in actually admitting what one of the trade-offs was, but this was what he meant by more resources to the front line. It was sacking a whole bunch of managers. But there are examples where we have good evidence about what matters and what doesn't matter. And this story is about what happened in A&E over the last 25 years, because it's a rare thing that we actually have really robust analysis about what matters in A&E. So when I first arrived, I was seconded to the A&E team in 2001 when the 4-hour target was set. And at that point, nobody had a robust idea of why A&Es were so slow. So one of the hypotheses was they don't have enough staff. There were plenty of other hypotheses, and we went out and examined them and got evidence about what worked and what didn't work. But right at the start, one of the first actions we took was to look at evidence about staffing and speed in A&E. And it so happened that the Audit Commission had done a big study of staffing and performance across the whole country. And it had lots of robust data in it. But the data said, staffing isn't a big factor here. It's not what's determining performance. So we went out, asked other questions, found things that did work. And in 2005, when the target had first been achieved earlier that year, the Healthcare Commission, the successors to the Audit Commission, repeated the staffing study. And this quote is one of the things they said. And bear in mind, we had increased the staff over this period, and we had improved performance so that almost nobody waited more than 4 hours in any A&E. And they said, well, there's no relationship between staffing and performance. There's no relationship between increases in staffing and improvements in performance. So we had a solid study. And this is broadly still true. I had a quick look at the staffing numbers on recent NHS data. Well, there's one of my HSJ columns has some of the charts from that. And the evidence doesn't look any different now than it did then. But we have more than doubled the number of staff in A&E, the number of frontline staff since 2010. So we seem to have ignored the original advice. Staffing wasn't the issue. And of course, performance, and this is from an old strategy unit report. This is what performance looks like in A&E over that period, starting around about when the original Audit Commission or the original Healthcare Commission did their study around here when the target was being met. Over this period, we've more than doubled the number of staff, but performance has just relentlessly fallen. And if I had to expand this to current performance, I'd have to do a much bigger slide because it's way off the edge of this chart. So that's an area, more staff didn't seem to help. But here's a different view of what Lansley's focus of more resources to the front line looked like in terms of its impact on the NHS. So the things to look for here, the two red lines at the bottom are managers. The blue line is nurses, the light blue line or the green line is doctors. So we've had a pretty big increase in doctors since before Lansley was Health Secretary, and a reasonable increase in nurses. We can come to some of the reasons why it wasn't faster later, but I don't want to go into the detail, but management hadn't even caught up with the level it was before Lansley was health secretary. So he managed to get rid of a lot of managers. That was the trade-off he made. And since that, since COVID happened, we've seen a very similar thing. The response of the NHS to fixing the problems it was having was throw staff at the problem. And we got a lot more consultants, a huge amount more junior doctors, a lot more nurses, and so on over the last 3 or 4 years. But NHS output has actually gone down. And at least one body, this is from the Institute of Fiscal Studies, and they reckon that productivity maybe went down 25% because of combination of lower output and those extra staff. So it's also worth going back to what we knew before Lansley cut management. Now, this is from the King's Fund report before the bill was enacted. We said, hold on, actually higher management is a good thing for the NHS. And we had benchmark comparisons as well. But management after that point was cut even further to get more resources to the front line. But that work has been repeated, or similar work repeated recently. Again, higher levels of managers can improve NHS performance. And there aren't that many managers, so it's not as costly as having far larger numbers of doctors. So again, more resources to the front line. If you cut management, doesn't look like a good trade-off given the best evidence we have, but that's what we've done. But that's not the only area that we've tended to cut. So this is another Institute of Fiscal Studies. This is a Health Foundation report done a few years back on NHS capital spending. And they, from the point where Lansley became health secretary, capital spending was slashed. And again, he didn't boast about this so much, but it was one of the things he did in order to be able to get more headline numbers of doctors and nurses at the front line. The level of capital spending at the end of this was roughly half the level in any other comparable health system. That's a much bigger gap to other health systems than the numbers of doctors and nurses we have. And here's a more recent analysis of the consequences of some of that. Well, some of these are related to capital. So we have far fewer diagnostic machines than most comparable countries. We're still vastly underspending on capital because the money's going to the front line. This is what John Byrne-Murdoch said about it. This is analysis is from the FT. The conversation has to move beyond more cash and more doctors. So the consequence of not spending enough on things like capital. Oh, I should say one other thing. It's not just that the NHS doesn't have a large capital budget to start with. If you read National Audit Office reports, it has also frequently pilfered those capital budgets in year to cover operating deficits, which means we've got yet another way to get more money on the front line, but we're taking it away and trading off money on long-term spending. So that seems like a bad idea to me. So final comments. I think that the whole idea of more resources to the front line, which basically means more doctors and nurses, it looks good in newspaper headlines. But the consequences of it, the trade-offs the NHS has made to achieve those numbers, whatever popular they look like in headlines, we've cut management, we've cut capital spending. We've also prioritized headline numbers of staff over the right mix of staff, even within the front line. And one thing I haven't mentioned, but this has also happened, we're focusing on hospital staff and ignoring and sometimes cutting community staff and primary care staff and spending on prevention, long-term spending, in order to pay for all those doctors and nurses in hospitals. My overall conclusion is, I think this has been a bad mistake.
Thanks, Steve. Already getting some comments in the chat, which we'll have a chance to return to. Are you able to stop sharing?
Oh, sorry. Yes,
no, thank you.
There we go.
Yeah, thanks. Ron, let me bring you in at this point.
Right. Thank you, Nigel, and thank you, Steve. Nigel introduced me as Dr. Ron Agley, so I must confess earlier now, and it has some relevance to what I will say. I'm no longer a clinician, I'm a manager. So I'm one of the people who made the transition from being a clinician, yeah, I know, to being a manager. So some of what I'm about to say reflects, I guess, some of the feeling around that and how people respond to it. Briefly, I'm going to cover sort of three things really. So a bit of building on Nigel's introduction to why is it we get into this type of conversation, essentially about one type of staffing resource versus another. Second thing, briefly about what some of the data tell us, to build on the really nice charts that Steve shared. And then just some observations about how we might have a less polarized discussion about this topic. So I think that the first thing about why we get into this type of discussion, I think at the heart of it is the experience of the public. And if I might simplify, I think there are some tropes here. So people see that they get seen by a doctor, they get cared for by a nurse, or some other clinicians who they often think are nurses, like therapists. And this is the kind of heart of the experience of the vast majority of the public who engage with health services. Those are the people they see, and those are the people they get value from. Managers are not part of that narrative or that visibility. So where we as managers tend to get into the narrative is that we're people who cut services or introduce red tape and bureaucracy. So it's not a starring role we have in this story, and I think that's something that politicians build on and exploit. And I get a reminder of this every time I do what I just did, which is to explain to a group of people or individuals that I've moved from being a clinician to a manager. So I think the public want more of what they feel delivers value, doctors, nurses, and there's no overt political narrative around increasing the people who are not so much part of the story, who are managers. But we do get a pretty consistent narrative about better management, and I'm going to come back to that later. So what do the data tell us about whether we've got enough of certain staff groups? So Steve has given us an outline of how trends have changed, but I'm just going to give a kind of rundown of some of the data around vacancies that help answer the question about do we have enough of? And this has been reported on quite a bit recently, so you'll be familiar with the numbers, but headline numbers for the NHS at the moment, vacancies for nurses are running at around 13%, and vacancies for doctors are around 8%. So on objective grounds, we don't have enough of either of those staff groups. And of course, there's a bit of regional variation tied in with that, and some interesting variation around settings. So some of those vacancy rates are significantly higher in the community and mental health sectors, where you could argue we need them most. Data on NHS management and vacancies is harder to come by. So I haven't seen any headline report saying, we've got a vacancy rate of 10 or 15%. And on ESR, that would be kind of clinical and administrative groups. So it's a bit harder. There isn't this narrative that we haven't quite got enough managers. There's no easily available objective data. There is some data to tell us what the vacancies are, but that obviously gives us the numerator, not the denominator. So I think from this quick rundown, the data make two things evident. If you look at what's happening with retention rates, for example, it's not only the case that retention rates are quite high and are increasing, but that means that we're finding it harder to hold on to staff, particularly nurses. And I think that for the year up to June 2022, the rate of nurses leaving the NHS was 1 in 9. And that was a 20% increase on what it had been for the 10 years previously, which was relatively stable. So not enough staff, clinical staff, if we measure it in terms of doctors and nurses, and the rate at which the nurses are leaving has increased. So that's, I think, some of the data that informs this kind of public view that we don't have enough of doctors and nurses. And Steve makes a really good point about, if you look at this in micro settings like ED, actually you can increase staffing, but actually if staffing capacity is not the constraint for performance in a particular setting, then it doesn't address the problem. But what I want to move on to is how do we have a less polarized discussion about this topic? Because I think the risks of a polarized discussion are that essentially as resources become more challenged, it'll essentially what we'll have is a discussion that pits one set of staffing groups against another, vying for that scarce resource, which will become increasingly adversarial, which I don't think will do either group, clinicians or managers, much good, and actually is likely to benefit neither in the medium and longer term. So we've talked a bit about the vacancy picture. So what's driving that? And is there something that I guess unifies this narrative? Well, part of the vacancy picture, pay is in the headlines quite a lot, and various staff groups have been striking for some time. But when we look at staff survey data and other information, it's not just about pay. It's much more about the climate, or it's also about, if not much more, the climate within which staff are working. So even if you believe that we need clinical staff and that we need those more than we need managers, it's unlikely to be sustained if we don't reduce the rate at which people leave. And this is what I'd call another example of the kind of bathtub situation. You want to fill the bathtub, you turn on the tap a bit more, but actually if you don't, if the size of the plug hole is also increasing and it's open, you don't actually increase the amount of water in the bath. And this is what we're seeing with staff. So the things actually that are going to allow us to have more of what I think quite a lot of people want, if you believe we don't have enough staff, are improving the climate within which staff work so that we don't lose as many at the rate we're losing them. And obviously that has implications for productivity as well. Now, that whole bit about the climate and the environment within which staff work, well, if management is not about improving, optimizing, and making that environment as good as it possibly can be so that people want to come to work, are able to work in a productive way where they can be themselves and bring their whole selves to work, then what is management for? So I think the link between these two things is not so much we need more of this or that. It's actually, if we want all staff to be able to work productively and fulfillingly in the NHS, then we need a better managed NHS. Does that mean more managers? It might, but we need to ask a different sort of question. So it's not just simply a case of more of one resource versus less of another. Now, pick up on a couple of points that Steve made. So the example about ED staffing, actually, that's a good example of system. So it might be that the staffing capacity constraint actually does, for ED performance, sit somewhere else. It might sit with social care. It might sit with community settings. It might sit with mental health services. So there is something there always about looking at wider system. And I think that was some of the flawed logic with the initial views about ED, that performance there was just about staffing in that particular location when you were the flow. So I will finish there. I think I'm handing over to Rebecca. Thank you.
Thanks, Ron. Yeah, I mean, I think let's come back to this point about obviously we dichotomize this slightly to sort of set off a discussion, but we'll perhaps route back to this. I like your bathtub analogy. The front line, however, calls to my mind more the generals of the First World War and their approach to the management of resources. But so over to Becky, who, despite appearances to the contrary, is not locked in our cellar, but is in is free to come and go as she pleases. Becky, over to you.
Thank you to Steve and Ron for those really interesting starting comments. And Ron has said, I think, some of the things that I would highlight. So my perspective is on this is as a GP. And I think the world of general practice is different from the hospital world, which Steve focused more on. But in general practice, when one uses the terminology frontline staff, our receptionists, care navigators, reception managers who are going in and out of the waiting room, resolving problems, are a really critical member of that team. And so actually the terminology is probably not very helpful. And your graph, Steve, actually showed doctors, nurses, and other clinicians, I think. So broadly, we're talking about, should you put money, I think, into clinicians rather than general managers and administrators? And that the other bit of the terminology in that is about medical and clinical managers. So with that said, the one point I want to make is about the particular issue of resources into administration and the invisibility of the impact of too few administrative resources. And if you think of that from a patient perspective, when you try and rebook your appointment, get through to cancel it, try and get your test results, and you cannot get through on the telephone, in the internet, over the internet or in person, that's a situation that's got more and more acute over the last 10 years or so. And the consequence for me in general practice is that, utterly frustrated by being unable to penetrate the hospital system, people then ask for general practice appointments to clarify things that actually a well-run and well-resourced administrative system could do. And yes, there may be digital technologies that will take up some of that slack, but the poor funding of administration in hospitals and the fact that that has been cut and cut and cut through sequential hospital sick plans really has an effect on the overall efficiency and causes patients, A, untold frustration, and B, to spin around the system in an incredibly inefficient way. So that's one thing I think is really important. The other thing I'd come back to is, I think, Ron, you were touching on this when you were talking about what types of managers. And if you were to have the counter argument that you have to reinvest in general management in a context in which there are not enough clinicians, you will, the frictions will increase, and managing a lot of what we have read about recently and we hear about is kind of at times very aggressive management of poorly resourced, poorly staffed teams. We've had the example of Bawagaba, the junior doctor who was covering, a department with insufficient support. No amount of general management can really sort that out if you don't have an adequate bedrock of clinicians there in the first place. And then the question becomes, how do you blend medical and general management effectively to achieve the kind of transformation that we need? And I think, Ron, that's really what you were alluding to when you said it has to be about not just doing specific tasks, but rebuilding a workforce, a blended workforce of clinicians, clinical managers, general managers, and administrators that between them can define the changes and improvements in efficiency that are needed and work collaboratively to achieve that. So the style of management is absolutely critical, and further investment without an approach that adequately draws on and engages both clinicians and also service users may not get us what we need. So I think I'll probably stop there.
Thanks, Becky. So we got an opportunity for comments from the floor. Please use the hand function. I'll ask my colleagues to intervene if they've spotted particular comments in. But I want to just go back, Steve, to your graph from Andrew Lansley, who might have said, well, actually, I accept many of your points, but the managers were doing the wrong things. And I wonder if that's a challenge now, is particularly given Ron's point, and also what we know about the importance of sort of particularly middle level management and supervision in terms of staff retention. I mean, often bad management at that level is a reason why people are leaving. Their rotas are badly managed, they're not looked after properly. So I just wondered whether we've got an issue also about where that management effort is directed. And again, people might want to come in on that, but I'll come to you on that. Maybe I might get you to reflect on that as well, if I could.
So I think it's fairly clear that there's quite a lot of bad management in the NHS. I mean, one of the things which affects people's quality of work when they are on the front line is, the managers are telling them you can't have time off next year to go and get married or whatever. And this just seems like crazy. There's no reason why managers should do that. There's also a lot of bad management in the kind of supervisory bodies in the NHS. I mean, quite a lot of them seem to spend their time doing stuff which doesn't help anyone. So ICBs, once upon a time SHAs, once upon a time PCTs, and NHS England itself. But one of the reasons why there's so much bad management is because good management squeezed out, because the demands from the centre often get managers doing trivial and useless work, which leaves them with nothing left to do adequate amounts of good work. I mean, we're about to sack 30% of the managers in ICBs. Is that a good thing or a bad thing? I mean, we're going to have ICBs that haven't got capacity to do anything else, but I'm not sure how many of them were doing really useful things now. But so I think there's a tension. The real level where we need a lot of administrators and managers is the operational level, the front line itself. We need people to coordinate processes, design better ones. And that's what managers should be doing. But when we've got them doing something else, then not only do we not have enough, but we waste their time doing things which don't help.
Thanks, Ron. Did you want to comment? Can I get you to comment on that? And then I'm going to come to Dr. Thusu. Thank you.
Sure. Thank you, Stephen. You'd said things in a way probably that I can't, but what I would say, there is certainly something about, and that's why I've been, I guess, not specific about the numbers question. I think we would all agree we want better management, and right now we certainly need more effective management. The central challenge being around that retention of staff for me, because too many are leaving for reasons I think that are manageable and preventable. So there's certainly something there about creating climates and environments in which people want to work. The root causes for why we seem in many places and at many times not to have that are manifold. I think there's a whole other discussion on that, but I think that would be the central point. So before getting into numbers, I agree with you, Steve. We need to look at what are we asking people to do, and are we prioritizing the things and the focus in the right way? My personal view is that there is quite a lot of nugatory activity in our whole management system. That's not by design of the people who are necessarily doing those things, but wider system requirements. So I think there's certainly an opportunity there to focus people that we do have on more things that are going to add value at that front line where it really counts, certainly.
I've got a hand up here, Dr. Thusu. Do you want to just turn your camera on for us? While there's a very charming picture, we can see it. It'd be quite nice to see you talk, if you wouldn't mind. There, great. Thank you very much. Good.
Hello there.
Yeah.
Hi there. Yeah, so thank you for that. Can you hear me okay and see my picture okay?
Yeah, you're fine.
Fine. All very interesting things, and there's nothing that I have heard so far that I disagree with. Now, I am a clinician in the NHS, and the reason I'm sitting in the car because I have to drive from one hospital to another to do another clinic. But I also happen to be a county councillor and a borough councillor, and sit on the public health and the new ICB boards. And the question I have to all of you is, all these things that are written, all these graphs that are shown are all excellent. However, the public do not buy into this. The local election that we just had, 3/4 of the literature from various parties is NHS based. We haven't got enough doctors, we haven't got enough nurses. Not one of them said anything about managers. And the rhetoric, and to convince any spending on the NHS going down further down the line, the public need to be convinced that money gets spent properly, and it's always on clinical staff. So the question I have is, how does one breach this? Do the politicians just need to ignore the politics part of it and just do what they need to do? Or is there some more nuance that other think tanks like yourself need to try and get out there to the public, saying it's all well and good having more nurses and doctors, but there are much more complicated aspects on it?
Yeah, a really interesting point. Let's store that one up, but I suppose so. My immediate thought on that is it's quite unusual to have a sector in which all the debate is about inputs as opposed to experience and outputs. Let hang on to those points, panel, and let me take Mark Cheetham, who's next, and then I'll go to Billy Palmer.
Thanks. Hi, I'm Mark Cheetham. I'm a colorectal surgeon. I'm a national GERF lead for general surgery at NHS England as well. This is a false dichotomy, isn't it? Because what we need is frontline administrative staff to take some of the burden off the smaller number of clinicians who are sometimes spending crazy amounts of time doing non-clinical facing stuff. So if you just look at surgery, surgeons in the UK spend far fewer days operating than their counterparts in the USA and Australia. So we're using very expensive people to do administrative stuff that someone else could do for them. So we're not getting enough bang for our buck. So I think we need both, but what do we want those admin staff to do? I think the problem is that a lot of their work has been focused around narrow targets of activity. And when you get a target, you get two lots of people, one person to try and meet it, and then a separate team to try and measure it. So we've got to reduce the burden of hitting targets, and they've got to be more carefully focused on things more broadly based around quality, not just access and productivity.
That's interesting. It'd be interesting to see, Mark, where those statistics. I mean, so anecdotally, there was a big feeling that we've got a lot of very expensive people doing administrative work for which, which actually would be better done by other people. But have the college or GERF looked at that systematically at all, or is that?
We haven't. It's really hard to pull out, isn't it? Because these posts have got very different names. And what's a manager? I don't think we really know what we mean by that. And the job roles and titles are not standardized across the NHS, so it's quite hard to work out.
Yeah, I mean, it's interesting in the chat. It's interesting that administration comes up as something that actually might be as or more important in many ways to pay attention to in terms of making big impacts on productivity and the best use of staff. Billy, over to you.
Yeah, I mean, something of what I was going to say is just been covered, because actually the very first thing in the chat was Becky's comment about what we really mean by a clinician and frontline, and is that patient facing time, which is interesting, and that's where we almost have no data. There's been sporadic surveys of consultants, for example, to try to unpick proportion of time they're spending on their direct clinical care versus other activities, but this is really important, and it's quite doable to have these time and motion studies to try to unpick it, but just people have chosen not to, and that's not where the sort of research funding and interest has gone into. So that sort of frustrates the ability to really unpick really what we mean by sort of frontline resources. I just wanted to make sort of a slight defense for clinicians in this. I guess there is an alternative evidence base to point at about the benefits of having fewer patients per clinician. And just sort of sense checking what's happened in the last 3 years, we've got 11% more nurses, same proportion for ambulance staff, slightly more increase in managers over the last 3 years, and actually double the level, 22% increase in staff in central organizations. And I don't know whether that plays into maybe the discussion you were just having about target setting and the burden that could create, but it's sort of quite noticeable. You've had double the increase across the ALBs as you have for nurses in this last 3 years. And just, I guess the point about what we see whilst concurrently, or what's sort of associated with increases in staffing, I guess we have to think about how they're increasing staffing, and the fact that this doesn't happen in isolation. There is a burden of education and supervision, and I think that needs to be thought about very carefully in terms of the long-term workforce plan. If there are going to be some bold ambitions in terms of increasing staff, well, what's the effect on the service? How many more additional facilitators and supervisors do they need, and how does that affect what looked like frontline staff actually losing capacity to do direct clinical care? There's an onboarding cost to it, and as sort of been mentioned, as Steve mentioned, the skill mix is really important here. In primary care, you've gone from 1-to-1 GPs to other clinicians to 1-to-2 in a 5-year period. So I think that's a very important part of the argument about this link between numbers of clinicians and sort of productivity and output.
Thanks. If Mike would forgive me, I'm just going to go to Becky, because I think you might have an immediate follow-on from that, and you might want to reflect on what Billy just said about some of the issues about the extra staff at the front line, and then I'll come back to Mike.
As Billy was talking, it made me think about what I was saying about if you have insufficient administration, the people on the front line, as Mark Cheetham said, end up doing all kinds of admin stuff they shouldn't do, and you get more chaos in the system, because it is the administrative backbone that helps patients to flow well along pathways, and when they're not there, you get duplication, errors, mistakes, frustration in patients. And so going back to what Dr. Thusu said, how do you make the case? I think probably everybody, either for themselves or for a relative, has had the experience of trying to contact and engage with the NHS in a way that is almost impossible now, because there isn't that administrative staff there. And just a public narrative about that, some exploration about that. I think stories that people tell and case studies can bring this to life quite quickly.
Yeah, I mean, there's a sort of one way of constructing Rishi Sunak's bid the claim to remove the 8 a.m. scramble is actually saying our administrative and systems and processes don't work for 300 million transactions a year, which
the
is
increased staff numbers that Billy was talking about. If we're spending 50% of that time doing avoidable or unnecessary or inefficient activities that could be smoothed out with good management and administration, you could get your efficiency gain that way, and that's possibly what's not happening.
And from to go back to Dr. Thusi's point, actually, the public would notice quite a bit of this quite quickly.
Potentially.
Yeah, potentially. Mike, thanks for bearing with us on that, and then I'll come to Leonora. Don't know if your camera's working.
I'm just
that'd be good
trying,
if it was.
Yeah, just trying to turn the video on. It's been a fascinating set of contributions. Can I say it almost makes you feel smug to have something you instinctively believe is true. It looks like it's backed up by the evidence as well, and it's been quite enjoyable to watch that. But the question is what to do, and I think, sadly we live in a world where policy and evidence on their own don't change the world. Is it sort of provocative to quote Marx and say the philosophers have only interpreted the world? The point is to change it. So how do we move to a better position? How do we move towards a more nuanced conversation? I mean, could I suggest, in some form, we need a campaign. We need an organized and proactive approach. Probably one I would say that explicitly puts at its heart, the voice of patients and service users. And if we wanted to do that, who would do it? If I thought, on behalf of the National Deaf Children's Society, that a more nuanced conversation about spending in the NHS was in the interest of deaf children, and if I wanted to give £500 or £1,000 to an organisation that was going to make this point actively on behalf of a coalition, I honestly don't know who I would give the money to. But how do we move from evidence to a proactive campaign of dissemination?
Let's return. Great question. I don't think we know the answer, but it's worth returning to. So thanks for that, Mike. Leonora, and then we'll come to Thea.
Thanks, Nigel. Yeah, I'm just sort of coming back on Dr. Thusu's point, and I noticed actually there's something in the chat about this as well. It feels to me that, so Dr. Thusu said, shouldn't think tanks be sort of, putting out a bit more that, the information is wrong about the number of staff and how that's changed. I don't think tanks telling the public and politicians they're wrong works very well. And in fact, in some ways, they're not wrong. And what I think we've had this picked up in some of the other conversations, is where this does really, people really feel it as a patient is on the admin side and on the kind of the inefficiencies, lost information. Everyone's had it. And we had a really interesting session at our summit with Engage Britain, and I noticed that Miriam Levin's written in the Times today, and one of her colleagues has put that in the chat. So there's something really interesting, I think, on how this is actually really kind of impacting on patients. A question for me, sort of taking that on, is if there's a general consensus from this discussion that we need kind of more management or admin, is there a shared understanding about what those roles actually are? A lot of the kind of red meat in the tabloid press has been around some of the sort of so-called woke roles around ED&I. There's been, I can't remember who it was, but there was a very kind of high-profile criticism of comms people in the NHS. Non-frontline roles are very broad and diverse. What are the ones that people think are okay? What are the ones where there are problems? I would imagine the answer to that is it depends where you are and where they are. But I think there's something interesting in delving into that a bit more as well. But also, thanks, it's a really interesting discussion.
Thanks, Leonora. Thea.
Thanks. So going back to a couple of the points, and maybe picking up a little bit what Leonora was saying, but also Dr. Thusu. I mean, we're talking about a dichotomy, making it a little bit oversimple, aren't we, by saying management and frontline clinicians? Because as Steve pointed out at the beginning, you know, we've had massive reduction in capital. We've had significant reductions in a whole range of areas. And what's made me think of is work that I've done in my organisation over a period of years, which is actually working with frontline clinicians and doing work to talk to people about, well, if you had £1 million to invest, where would you invest it? And what's really interesting, just as a game, what's really interesting is how much clinicians talk about the need to invest in HR. We've not talked about that. Workforce, really good workforce processes, hiring, really good support processes, as Rebecca was saying, in admin, really excellent IT. You talk to a group of clinicians about what gets in the way of their lives on a day-to-day basis. They'll talk about excellent IT and excellent IT support, etc., etc., etc. So I think one of the things that Dr. Thuso in his role as a counsellor could do more of is potentially talk to clinicians, and clinicians will make the argument for you about why you need to invest in all those other things that make life better. And it isn't simply more doctors, more nurses, more physios, more OTs. Of course, those things are important in the right place, but they will tell you the story about what makes their world better. Thanks.
So, sort of conceptualizing this actually as giving people the right tools and environment and support to do their job, which then means you take the debate away from this. It is an artificially framed false dichotomy to get a debate going. But if we actually said, you know, if we want to make Mark's colleagues in colorectal surgery more efficient and more productive, and to make their jobs more enjoyable, so that they will stay, what would be the things that you would do? And one of those would be providing proper administrative support. Giving all the junior doctors a PA is one experiment I've seen. I've never seen it written up, but for instance, but also giving them equipment that doesn't break down, roofs that don't leak, and IT that has one login and works first time. So actually, maybe shifting the debate that way is a much better way of framing it, and would be an easier sell. Let's go to Ron, and then I'll come to Steve.
Yeah, thank you. And I like the way this has evolved. So the answer to that question about what's useful for politicians to do, I genuinely think there is probably not much mileage, and it's not for me to advise them. I think they get plenty of advice in trying to champion we need more managers. I don't think that'll ever be a vote winner. But there's something here though. And what's the metaphor here? I'm going to use a slightly crude one. We sometimes watch football matches, cricket matches, those of us, or whatever sport you're into. Is the role of a manager in a way that of a referee, in that if they've had a really good game, you don't notice they were there? The participants, the players might, and appreciate that. Whereas the spectators go away thinking, well, that was a really good game or something, but not necessarily noting those who was there. So I don't necessarily think this is something that needs to be championed. But the space for that dialogue actually is within our organisations and in policy circles about how we improve the effectiveness of the management that we do have. And I think there have been some themes there. But does it need to be brought to the public consciousness? I don't think so. And I can think of a whole set of other services with which we engage. I don't go to the supermarket and wonder, how many managers have they got at Tesco or something like that. This is just not where, when you're in a service industry, these are not things that exercise people. And I think it would be unhelpful in many ways if we tried to go to that particular locus. So the thing here is, what kind of internal dialogue do we have within our organisations and in policy circles at system level about the kind of impact we want? And to Nigel's point, it is this focus on inputs rather than the outcomes that we want. And of course, there is a bit of focus on outcomes as well. Waiting times, a very strong focus, safety, those sorts of things that we want to talk about. And there are a number of enablers. So I do think there's something there about shifting the focus to outcomes, not so much for the public consciousness, and actually within our organisations and policy circles, then understanding how better we can direct the resources that we do have to making sure that it's better managed.
Thanks for that. Great point. Steve.
So I've got a couple of things I want to say about some of the general points, but one, just to respond to something Billy said, when we're talking about percentage changes in the numbers of different groups of staff, it's worth having in your head what the baseline numbers are. There are only according to ESR, about 30,000 managers in the NHS, and only about 10,000 senior managers. So a 10% increase in senior managers, which we have seen recently, that's only 1,000 people. 10% increase in doctors is 13,000 people. A 10% increase in nurses is well more than 35,000 people. So the managers are a tiny percentage, about 2% roughly of the entire workforce, which we think is far too little. So don't look at the percentages. That's just, I made a sin myself by talking percentages rather than absolute numbers, but that's an important thing to bear in mind. Don't, especially when looking at recent numbers. But think the more general thing, I think Thea made this point best. What we actually want the system to do is to make effectively, which investment should I make that will most improve the quality and productivity of the system? Because that will get you a much better answer than talking about the one input, only staffing. And the thing that I think I'm arguing is there's lots of other investments we should have paid a lot of attention to, because they will improve the productivity of staff, improve their ability to spend time with patients. And a lot of those investments are not putting the money into more staff. Indeed, we could probably radically improve the output of the NHS by giving them better environments in which to work, by having better operational managers to smooth things out locally and coordinate things better. But they have to have a proper, which investment would make the biggest difference overall. There's another thing about that. I think Sunny made this point about public knowledge. So the public won't support a campaign which says more managers. Well, I don't think we should trust the public to make a judgment about what works in the system. We should trust politicians to know the difference between a slogan in a campaign and what actually works. And we have had people who know this difference. So in the early 2000s, I think the Secretary of State and the people running the NHS and the Prime Minister understood that what mattered was getting the performance of the NHS to improve radically, vastly reducing long waits, vastly reducing A&E delays. They knew the public would reward them if they got those outcomes. But they also knew that there was no point in going in with silly slogans about inputs. They actually had to understand which interventions would work in order to be able to get the public back on board with thinking the NHS was a robust and good system. Now, what we have at the moment is we've got repeatedly on both sides of politics, people talking about the inputs instead of recognizing that it's a complicated system and they need to understand what works or they won't get the improvements. I think that's a very important point. We can't just do what the public say they want. What they really want is a better NHS, and you need to know how to do that.
Thanks, Steve. I think that's really interesting. I think that picks up some of Thea's points as well. And I'm left thinking, and we've got about 15 minutes left, and there's a number of comments in the chat that we ought to pick up, but we ought to return. I think perhaps before we go, return to this question of all of those interventions that would improve productivity, working life, work quality, because there's probably a lot of people who've got that information, and you could almost draw a reverse driver diagram, and undoubtedly better administration and computers at work and other things would be in that, and that might be a really good way of reframing all of this debate. I think I had a comment about how all of this feels in the sort of general. Alison Powell has a question here about which Becky you might want to respond to, which is, so what's it sounds like I think you were referring to this. Did you want to? It's at 12:52 in the chat. Have I'll read it out. Previous studies have shown that hospital staff lose as much as 10% of their working time to interruptions and operational failures. What about general practice? What sort of avoidable disruptions do GPs encounter, and how would these operational failures be addressed?
Yeah, I mean, it's a great study that this institute did that Alison's posted there. It's really interesting to read, and I'm sure it also reflects what happens in hospitals as well. But I think what it made me think of, that study, is that there is an immense amount of inefficiency within general practice. Some of it generated by the overspill over the boundary from hospital problems that people bring into primary general practice, and other bits simply because practices have very inefficient processes. And the GP recovery plan, which has just been launched on Tuesday, has within it some proposals, logical and well-founded, about using digital technology and to improve access. And it recognises that it's not just a plug and play. It recognises that you have to, design and implement these things carefully. My own practice has just gone through this. We launched 3 weeks ago. It's gone pretty well, but it's taken a huge amount of collaborative design and implementation work across the clinicians, the receptionists, the general managers, external IT supporters, the IT company themselves. And if we don't get that right, then the kinds of interruptions and operational failures that are highlighted in that report will persist. If we do get it right, then we really, really iron them out. And we've been really lucky to be buddied with an organisation that has been working on its digital transformation and digital access for 3 years. So we've learned a huge amount from them through a kind of buddying process, which we haven't talked about here. But given my experience of the last 5 months setting us up on this, that's another really good way to spend additional resources. Learn in an intimate way from the people who've been doing it ahead of you. So it's part of the mix that people have been talking about. It's not just people, it's not just roles, it's a whole approach, a whole philosophy of change, implementation, driving for efficiency that has many different components, and that this report is really interesting to read. I'd recommend it.
Yeah, great, thank you. Other comments or questions? Put your hand up, and I will bring you in. I don't know whether my colleagues who've been monitoring the chat want to highlight anything particularly at this point.
No, I think that was my job, Nigel.
Oh.
So we had quite an interesting one earlier, bringing it back to sort of systematically some of the things we've spoken about what management means, which might be for Steve or Ronald. And that was from Rob Newton, who said, what does evidence tell us about the types of management which add most value by adding to or protecting? Is it administrative capacity, operational management in providers, improvement resource in providers, commissioning and planning, or strategy in ICBs? If you break it down like that.
Oh, can I comment on that? I'm not sure there's been any robust analysis of different types of managers. I think there's good evidence about operational managers, I think, because some of the reports I quoted were really talking about operational managers somewhere in the front line. We know that hospitals who've got more of them actually do a better job financially and in quality terms, clinical quality terms. So there's some evidence there. It's very, very hard to argue that the overarching people who do strategy, or the multiple layers we have between the Secretary of State and the actual operating parts of the NHS, what do they do? What value do they add? One of the things they could do, and I've certainly argued this recently, the NHS England, the leadership there, could set a very, very tight and clear focus for what it wants the NHS to do. But they've spent 10 years not doing that. Everything is an issue of focus, which means everybody decides for themselves what they want to focus on. That's something leadership can do and has done in the past. That was one of the successes of the early 2000s improvements in the NHS. Everybody in the NHS knew, because it was set right down from the top of the Department of Health, these are the 2 or 3 things we want everybody to do, and you'll get sacked if you don't manage to achieve improvement in them. That was focus. That was clarity. And the current system right at the top doesn't have that. So we know what they're not doing, but I don't know whether we can see what benefits they do if they do it right.
Yeah, thank you. I certainly see that replicated a bit at ICB level, and some of the ICBs I've worked with huge amounts of really good work going on, but just so much of it. I mean, almost unmanageable. Mark, what's your perspective?
Yeah, I
on
just
that?
want
And I'll come to Ron.
just kind of follow up on Steve's point. I think a lot of this is about style of management, and what I see is a real overuse of command and control from the centre, which is disempowering and a real turn off to frontline people, and I include frontline managers to that, because it doesn't allow you to adapt the issue to the local situation. It doesn't, you don't have any skin in the game. It just becomes about imposing something that Whitehall thinks was a good idea, and often it's not by the time you get there. So I think what I'd like to see is managers at the front line adopting a more collaborative kind of coaching style of working with teams across clinical boundaries to get the right result. I think that would have a huge impact on the way we do things. I guess the question is, where does that command and control style come from? A lot of it's role modeling. I think sometimes people are inexperienced and overwhelmed, and that's their kind of default style that they go back to. So it will take a real sea change to get there.
Thanks, Ron.
Yeah, thank you, Roger. This is really interesting, isn't it? So just Steve, what I would, it doesn't necessarily feel when you're sitting in an acute trust that there's an absence of guidance from the centre.
To be fair, I'm not sure that's what Steve was arguing. I mean,
right.
Yeah.
Well, sorry, Steve. That's how I slightly heard it. But there is quite a lot of guidance, and I think part of what we now have another layer, at least in the system, with ICBs and ICSs, and what some people might view those layers are doing is helping to decipher what is coming from the centre and turning it into something local. But the thing that I think is really interesting here, and I don't often come to these conversations but thinking we need more data, wouldn't it be really good at an organisational level to understand the different sorts of management roles, formal and informal, and what amount, and I don't think it's so much time and motion. I would just do the first thing of how many people are actually performing management roles and of what type. And we could use I think there've been some suggestions about the different sorts of buckets. I've not seen a single organisation that has that's done that sort of analysis. And dare I say, it would be a good thing to partner with an organisation to do and to understand, and then use that as a basis for, well, what might be shifted? Where might you change emphasis to maybe get something more effective? But I think that's a data-free area at the moment, or at least an insight.
Yeah. So some years ago, in fact, probably when I first joined the trust, I thought that it'd be very interesting to look at middle management. There had been a big set of studies, which I think Mark Exworthy has put in the chat a reference to, about this sort of middle management. And the problem that we bumped into is there is no. So a middle manager ranges from someone with no staff, virtually no budget, to somebody with, the staff the size of a division, and the budget the size of a small country, and there's no sort of real taxonomy about how to describe these, which is one of the reasons why it's very hard to research them. I mean, although Billy and colleagues could also report, I don't know how many different types of advanced practitioner, nurse practitioner titles are there in the. Alison Leary had done some study that suggested it runs into tens of thousands of different titles across the NHS for roles which sound like they might be quite similar. When you then look at them, you have roles with the same or very similar names which are totally different. Is that have I summarised that correctly, Billy? I think that's, yeah. So that's a kind of interesting thing. I just don't know if we know who, and actually it's been interesting in this conversation, hasn't it, that we've slightly conflated administration with management. I mean, I think actually they are different. They're both important. There's been a bit of a tendency to over-privilege leadership, I think, quite often in this discourse, as opposed to some of the more boring and basic, but actually in some way, in operational terms, as if not more important roles that the administrative staff do. Yeah, thanks for those points. I think we're sort of getting to the end, so we've got time probably for perhaps a quick reflection from. I'm going to go back to my panel, and I'll go Becky, Ron, and Steve, and then I don't know, Leonor, if there's anything you want to add, but I'm going to then try and sum up, because I think we've got about 6 or 7 minutes before we need to stop. So, a
very quick comment from me, which is that I think during this discussion, what struck me is that it's less about numbers, or it's as much about numbers and amounts of money as it is about the context of the style of management, the local freedoms to adapt and adjust what you're doing and the way in which you're doing it to local context, and the need for absolute collaboration between a management cadre, frontline staff, other frontline clinical staff, service users. And without that, and a strong focus on creating a supportive environment in which people want to work, you can tip as much money in as you want, but you probably won't get the outcomes that you want.
Great, thank you. Ron.
Yeah, thank you. Really interesting and helpful discussion. I'd echo the point, not about the numbers, it's about impact and outcomes. Things to find out more about. It's made me reflect actually just how little we might know about what management looks like. For me, in a typical acute hospital organisation, but right across the sector, the different roles and the numbers and resources directed within those different roles. So there's quite a bit more to understand. I think there's another discussion to have on this when we have some better information from maybe one or two organisations about what that looks like in practice. But the things that we put together as management actually cover some really widely different sort of roles at the very senior end to some administrative roles that are really valuable as well. And the interesting thing, I think, in this, the focus of, there's been a lot of dialogue in the media about numbers. The risk is that each time there is a cull of numbers or some sort of constraint on numbers, we lose numbers at the administrative and clerical end. And that's maybe not where we need to lose them.
Thank you. Steve.
So I think, as one way of summarizing some of the things we've talked about, that more resources to the front line as a phrase is a summary of a naive attitude to how a complicated system works. What we need is people to recognize that in a very complicated system, we need to understand all of the inputs if we want to make the system as a whole productive. So we can't have people working in a hospital where the ceiling is falling in because they won't be able to do their job. But if we don't spend the money in the right place, we'll have ceilings that fall in. Equally, if we don't have enough managers, we'll be trying to operate a high performance engine without putting any oil in it, which might save you money over a year or two, but eventually the engine will seize. And when we discuss the NHS, we need to move beyond these simple slogans and recognize here's a mix of things we ought to be doing. Look at benchmarks against other systems. You know, the NHS literally spends half the capital of most of its comparable systems. So where do we need to put more in order to increase the overall quality and performance of the system? And if we can elevate it a bit to that level, instead of falling back on these naive slogans, then we will have made a big improvement in how we think about the system.
That's a great summary. You've kind of, so we've actually had the debate, we've had a debate on two sort of levels. So the false dichotomy has opened up quite an interesting interesting perspective. I think it's raised a whole set of questions about how to get management and leadership better, and that sort of micro level. But I think Steve's broader overarching point is, and it speaks to Sunny's first question about how to present this, is actually we should be making an argument about giving the system the tools to, thinking about how we invest in terms of staff, capital, other types of infrastructure and support to make sure that the people who've got to do the job can do it really well. And that detoxifies a bit of the management debate, I think, because it's then not about, that's just one component in a much more complex and broader system. So I think with that, I'll say thank you to Steve and to Ron. Ron, you had your hand up. Didn't want to just? I've just summed up. You can't.
Thumbs up.
Yes, fine. It's a thumb. It was a thumb. Good. Because I think if I have one role, it's to make sure that we finish on time. Thanks to Becky and her colleagues in my team for putting this together, and to Steve for his thoughtful opening remarks, and to Becky and Ron for their comeback, and to you all for your contributions. It's triggered me off to think with some very interesting thoughts, particularly some of Mark's comments I thought were particularly particularly helpful. I think we need an excuse to go back and talk to Andrew Lansley. So thank you, everyone. We will do, I think the next, I'm contemplating the next one of these might be looking at the mess that we've made of the front door of our healthcare system with all of the different layers of changes that we've made with various types of alphabet soup of acronyms and archaeological layering of initiatives that don't actually fit together, but very much pick up the same theme that Steve was talking about, which is this is a complex system, and if you try and optimize one bit of your system, don't be surprised if the whole system doesn't get optimized. So with that on that bombshell, I'll say thank you all very much for coming, and we'll hope to see you soon.